Hello everybody, I'm Liz Darlison, Chief Executive of Mesothelioma UK. I'm also a consultant nurse at the University Hospitals of Leicester, and many of you will know we've been conducting a series of interviews with people of interest or people who work in areas that we think may be of interest to the mesothelioma community. And part of this has just been about putting material out there, things of interest to keep our mesothelioma community together. And if you have any questions or concerns after you've watched this next interview, then as always, please don't hesitate to contact Mesothelioma UK. One of the nurses will be glad to have a chat with you. So it's a real pleasure to introduce somebody who I've had the pleasure of working alongside at the University Hospitals of Leicester for many years. In fact, let me just think, Annie, how many years it is. So I started working with you, I think, in 1987.
Right.
So that's however many years that is. That's when I first joined the critical care unit, and you were already there, I think, at that time.
Yeah,
so,
I was. Yeah.
Yeah, you were definitely there. So it's a great pleasure to introduce Annie Law. And Annie, if you don't mind, I'm going to hand over to you. And would you please tell people what your job title is and where you work?
Yeah, I'm Annie Law. I'm an acute oncology advanced nurse practitioner. I predominantly work at the Leicester Royal Infirmary, which is where our team is based, but we do cover the other two sites in the trust, which is the Leicester General and the Glenfield Hospital.
Lovely. And what I should have introduced you as Dr. Annie Law. I do apologise. I'm so proud of any of my nursing colleagues who managed to complete their PhD alongside working full time, and you are one of those people who many of us have absolute respect for what you've achieved academically. So forgive me for that. So Dr. Annie Law. So Annie, your service is that you work in, that you established at Leicester. So you're a real, real pioneer for acute oncology services. And it's one of those services that unless patients actually have any contact with you, they may not know that you exist. And I just think it's such an amazing service that it's a safety net behind all cancer services that unless you come across it, you don't get to know about it. And I just thought, let's shine a light on it a bit, because I think it's really reassuring to know that there are expert nurses like you available if you need them. So can you just tell us a little bit about what acute oncology is? What does it mean? And what expertise does that mean that you and the team that you have have what you work with?
Right. The acute oncology service came about quite a few years ago now, and it was on the back of a government report that was actually looking at the care of people who had complications of their chemotherapy, particularly neutropenia, when their white cells drop and they're at high risk of infection. And they found that if they were admitted outside of an oncology department, the care they were getting was suboptimal. And the government recommended that any hospital with an emergency department or an acute medical unit should have an acute oncology service to help manage these patients. Excuse me. Our service was set up in 2013. Excuse me, I've got a tickle.
I've got to say, although Annie is a real ale lover, that is not real ale she's drinking.
No, that's Coke. Yeah, so our service was set up, and we are sort of tasked with seeing people admitted to hospital, complications of their treatment, complications of the cancer itself, or those patients that are diagnosed with a cancer during an emergency admission into hospital. And there is a fourth category, which is basically anybody that any other team think we should see while they're in hospital. So it's a bit of a catch-all service.
What kind of service though we need that's really broad, that doesn't have all these different criteria that you have to meet? You'll basically take a look at anybody who needs acute oncology services by the sound,
providing they've got cancer.
Yeah. Yeah, provided they've got cancer. Yeah.
Yeah.
Sorry,
So it's there's just 4 nurses in the team, and we cover 6 days a week. We do have some input from some of our registrars and a couple of consultants who will come to see patients that we feel it would be helpful for them to see. We generally just work 9 to 5 every day, and I think one of the key things that we've changed over the years is those patients that are found to have a cancer when they're admitted as an emergency, because in the past the patient would come in, they will be found diagnosed with a malignancy, told about the diagnosis, then sent home, not knowing who to speak to, who to ring if they hadn't heard anything, what happened next. Now we talk to the patients, we explain to them what's going on, we explain the next steps, timings of the next steps, and we act as their temporary key worker. So they have our contact details when they go home, so that they've always got someone to speak to if they've got any worries, concerns, or they've not heard anything. So that is definitely one benefit, I think, of the service.
And so, Annie, how do you work alongside, like, the breast cancer nursing team or the lung cancer nursing team? So if a patient turned up in A&E unwell with whatever kind of acute oncology incident, how do they know whether to get the breast team, the lung team, or you? How does that relationship work?
Yeah, the majority of people in the hospital will automatically refer to us if it's somebody who's admitted as an emergency, purely because I think they know that they're going to get a very rapid response. So we're not experts in any particular cancer, we're a bit of jacks of all trades, but we liaise very, very closely with the tumour site specific teams. In fact, a lot of the MDTs for the different cancers will refer patients to us if they've had a referral and they find that the patient's an inpatient. They'll ask us if we can go and see the patient before the MDT, because it helps them with their decision making. And particularly the lung MDT, they're one of the biggest users of our service in terms of asking us to go and see patients to see how they are, what the patient knows, what the patient wants. So it can help make the decision at the MDT.
And do you have your own weekly team meeting, or is it all about centres on the tumour site specific team meetings?
It's mostly the tumour site specific team meetings. We have a weekly MDT for the cancer of unknown primary patients, which is part of our service. And that happens every Friday, but we don't actually have weekly team meetings because we work so closely together. We literally discuss patients on a daily basis, bounce ideas off each other, ask for advice of each other. So it's almost like a daily meeting we have. And as the team leader for the nurses, I try to keep a handle on all the patients that we're seeing, because I'll tend to be the one that gets the phone calls if there's any queries about any of the patients.
I must just point out as well, people know that we love acronyms in hospitals and in healthcare, and cancer of unknown primary, it's called CUP, we call that CUP. And so if people have ever heard the term CUP, that's what we mean. It means that we know somebody has a cancer somewhere because we've identified cancerous cells. What we've not actually managed to do is identify which part of the body that cancer has originated in. And so they often come under your care as well, because it's difficult to know which tumour team to align them with. Is that correct?
That's right, yeah. So we're the two of us are the key workers for those patients. So we will see them in the same way that a lung cancer nurse specialist sees her patients. We will see them right through the whole of their journey and support them all the way through.
So can you talk us through perhaps just Oh, the other thing I wanted to ask is our acute oncology services, have they managed to get established in all of those areas that the government first recommended? So all hospitals, acute admissions, kind of A&E, acute medical units, have they now, most of them got acute oncology services?
I think the majority have, but there are a few that have struggled. Some of those areas that are in more remote places, I think, have struggled to either set the service up or retain the service as it's gone on. And you will find a big difference between services that are in a cancer centre, like we are in Leicester, and a DGH, a district general hospital, that might not have oncology or haematology beds. The patients would always be predominantly in medicine.
And can patients self-refer as well? So could a patient, if a patient's been known to you previously, can they pick up the phone to you again? And
we have had that happen, yes, and we never say no. We get referrals from anybody. It doesn't have to be a doctor. It can be a nurse, a physio, OT. We've had relatives and patients ring us as well, because we are also the spinal cord compression coordinators for the whole trust, and the leaflet that's given to patients has our contact number on, so they will often ring us as well.
so that you've already mentioned about neutropenic sepsis, so we might need to just explain that in a bit more detail, because people who haven't had chemo might not understand, because they won't have had that explained. And you mentioned spinal cord compression, so I presume they're two of the acute oncology incidences that you would manage. Can you perhaps explain those a little bit and just tell us about any others?
Yeah, I mean, neutropenic sepsis is normally a result of chemotherapy, and it's where the white cell count in the blood goes down to a very low level, and it puts the patient at high risk of developing an infection which could lead on to sepsis. Because when their white cell count is so low, they're not able to fight the infection themselves. We have to fight it for them, and they can become unwell quite quickly. But if we get there quickly, we can treat them and get them back out of hospital and onto their next chemotherapy treatment. Spinal cord compression is where the cancer is in the bones, usually the bones in the back, and it presses into the spinal cord and can cause pain and other symptoms. But if we catch that early, again, we can treat it and get the patient walking out of hospital back to enjoying their life again. There's absolutely loads of acute oncology problems. The common ones tend to be those two, plus a high calcium level. A cancer in the chest that is pressing on the big blood vessels in the chest. Some patients get a buildup of fluid in their tummy, and we will see those patients, and there's two of us in the service at the moment that insert drains into the tummy to get that fluid off, to make the patient more comfortable. There's so many acute oncology problems. It can be anything, and especially with all the new treatments that we've got these days, there's lots of new acute oncology problems that wouldn't have existed a few years ago, especially with things like immunotherapy and the side effects that they bring.
Sorry, I'm myself, because one of my doggies decided to have a little bark there. I guess one of the key messages that I would love people to really hear loud and clear is that if something doesn't feel right at home and you're concerned, you know, maybe your appetite or slightly swelling tummy, or you might be feeling a bit fuddled or confused, or you know, anything at all that you're worried about that's different for you, reach out to your cancer team. And there are services like yours that are going to do everything they can to address the problem. And there are interventions that can make your quality of life so much better.
Yeah, absolutely. And that's the main focus, quality of life. Most hospitals will have an emergency helpline for the oncology service, not necessarily our service, but where people can ring to get advice, or ring your cancer specialist nurse. And if they're concerned or they're not sure about anything, they will, certainly in Leicester, they ring us as a team to get advice and support. Sometimes it might be that we can help just by a phone call at home. We can often organise prescriptions and things that might help. Or if it's something of real concern, we would make sure you came into hospital to be assessed and given the appropriate treatment that you need.
And I have to say, Annie, and I hope you don't mind me saying that, although I've been aware of your post, I didn't realise how much your team had grown. And we were just saying before we started recording that in the NHS, teams and services don't grow unless they work. And you know, your team has grown. And across the country, the number of acute oncology nurses has grown drastically, really, over the last kind of 5 years, which is a testament to how successful these posts are. But
Yeah.
so although I've always known you there, and you know, I've probably taken the service for granted, it wasn't until I had you know, a close friend who ended up in using your service recently, and you know, I was blown away really by, once you and your team got involved, everything started to happen, got put into place, and you know, for the first, this person had been in pain at home for quite a while, and you know, it just all, everything fell into place, and his quality of life improved drastically. And I just thought, wow, you know, I was wowed, and I've worked in cancer services for a long time, so and I feel sad that it took that to remind me, really. So you know, I'm hats off to you and your team. And it wasn't just that, it was just you know, to be able to pick up the phone and talk to somebody who knew what was going on, what needed to happen, what you were booking, why you were booking it, and what the possible outcomes could be and what we're going to do about it, you know, all over the phone, was just so reassuring for the family.
Yeah.
You know, it was absolutely excellent. So you know, I do hope that people feel really reassured that, I mean, most cancer patients never need your service.
No, that's right. But if they do that, you know, we're there, and we do try to respond very, very quickly. And our service is very much about liaising with other teams to get things done. And I think over the years we've built up a good network of contacts so that we can get things done in a more speedy manner. Which obviously is to the benefit of the patients and the families. And communication is always key. When especially during this last year or so with the pandemic, we've made sure that we've communicated with families after we've seen a patient to let them know what's going on, or we've had the family over the speakerphone when we've been seeing a patient, or on a video link on a phone. So we always try to include the whole family if that's what the patient wants.
And on that note, Annie, because we've read a lot in the press and heard a lot in the government briefings and so on about the impact of COVID on cancer patients and delayed diagnosis, and patients being further along in their cancer's natural journey at the point that they're diagnosed. Has that put added pressure on your services? Have you found that people have presented with more acute oncology needs?
Some have, yes. I think a lot of people have been sitting at home, perhaps with symptoms that they might have seen somebody a bit earlier. And I think one of the issues is a lot of the GP consultations have been over the phone rather than face to face. So it has presented more difficulties. And then by the time the patients come into hospital, their symptoms have been quite complex, and we've really wanted to push things through even quicker to get them to the point where we've got a full diagnosis and we can start treatment, because they're often poorlier by that stage. And one of the key focuses really about the service is really trying to get that diagnosis of cancer as early as possible, so that patients are well enough to have the treatment. And there will be a new clinic being set up very soon, which we will be part of, which is all about seeing people with those vague symptoms of a cancer that don't fit into any other pathway, where they can be seen by a group of people to facilitate quick investigations and diagnosis. And this is an outpatient service, so we can try and cut down the number of people that get diagnosed as an emergency admission, because waiting until it's an emergency means often the patient's not well enough for treatment, or needs it very, very quickly, so that we don't miss the opportunity to give them the treatment.
And will that be a nurse-led service, Annie, or will that be a team?
It'll be a team approach. There'll be a consultant. There will be some advanced nurse practitioners. Some of them will be from medicine and with oncology input, because a lot of the patients, they've done pilots around the country, and a lot of the services find about 20% of the patients have a cancer. The other 80% have other acute medical problems that haven't been diagnosed through other means.
Interestingly, I was on a call just this week with some senior people in cancer services, and I forget how many people are referred with suspected cancer in England alone. But the pickup rate, so the specificity of those referrals, is somewhere only around 6 or 7%. So actually, identifying 20% of people is pretty high.
It is, yeah.
For people with very vague, non-specific cancer kind of so that's really reassuring. And just to clarify to people, generally speaking, cancer services, diagnostic services, are modelled around the outpatient facility. So that is the pathway is modelled around being diagnosed through outpatients, and that's why as well going into hospital is outside of that model, and that also doesn't help with getting access to investigations and access to specialist nurses and the specialist doctors and so on.
That's right.
So that it's another reason why it's really good if we can try and get people diagnosed through the outpatient kind of model, because it's a much more common pathway for diagnosing cancer. I guess to really, I suppose, finish on, I wanted to and please, you, Annie, tell me what your thoughts are. But with mesothelioma, the common problems that I see people presenting back to us who might tap into your services or need your services would be fluid accumulation. That would be the most common that we would see with meso, whether that be in the abdomen or in the chest. And I don't know, and sometimes around the heart. So fluid accumulation around the heart, in the chest cavity, or in the abdominal cavity. With that, would you agree that and they are things that we can sort those out?
Yeah, absolutely. Certainly we would see directly those with fluid in their abdomen, and we would drain that fluid off. And then the patient, the first time we meet the patient, they have our contact details, so they can self-refer when that fluid accumulates again. So that is probably the most common reason for us seeing somebody with mesothelioma. We do get the odd one that we find a new diagnosis of a mesothelioma that we're involved in, but the majority, it is complications of the actual cancer itself.
Yeah, lovely. And outside of mesothelioma, just the two most common things that you deal with, would you say?
Ooh, what, in terms of cancers?
Yeah, so well, just the most common acute oncology things that you deal with on a day-to-day basis. What would be the most common things you're called to A&E to deal with? Sorry, I put you on the spot a bit.
You have, yeah, that's a difficult one because it is so varied from day to day. And I guess we feel that we see a lot of patients with spinal cord compression and fluid in their abdominal cavity purely because that's part of our service. So we get about 300 a year of people with suspected spinal cord compression. About a third of them turn out to be actual cord compression, but that's good in one way because it means we're then avoiding it in those that turn out not to be. We see about 600 patients a year that are diagnosed with cancer during an emergency admission, and probably between 2,000 and 3,000 patients who are known to have a cancer who've got complications of the cancer. We don't tend to deal with those with complications of their chemotherapy because they get admitted directly to the oncology department. We spend most of our time visiting A&E, medical wards, orthopedic wards. We get a lot of fractures from the cancers. Or over at the Glenfield, seeing them on the assessment unit there.
So it's very varied, very varied.
Very. We don't know when we arrive in the morning what we're going to be faced with.
Well, that sounds my kind of job in some respects, because
Yeah.
it's all about people, helping people, and having a lot of variety in your job. And all I can say is, I think, you know, you must feel very proud of the service you provide. You know, patients have told me how excellent it is, and now having had a friend, a really close friend, go through that service, it's an amazing service, and you know, a real flagship nurse-led service that you know, I just think it's excellent. So thank you so much
That's okay.
for sharing time with us today to talk about it. If people want to know a little bit more about oncology, is there where would you recommend that they could get more information? Would it be their Cancer Information Centre, or is there a body or an organisation, or?
The UK Oncology Nursing Society have an acute oncology forum, but to be honest, if you just Google acute oncology, you'll find so much written about it now that it's quite easy to find things. And there is a little tiny podcast that I made soon after starting the service for GPs. So apparently, if people just Google Annie Law and acute oncology, they'll come up with the podcast.
Well, that's awesome. Yeah, lovely. Well, thank you, Annie. I think it's been hugely reassuring for people to know that if they hit on troubled times with their treatment or their cancer, that you know, there are all these added layers of experts available to them. And it sounds like it's a very comprehensive service virtually across the whole of the country. So thank you for being the voice for acute oncology, and lovely to connect with you again.
Yeah, and you.
Yeah, and thank you very much.
Okay, thanks a lot.